Friends, this gives me a great pleasure in introducing my colleague, Professor Prabhavathi, who has been a professor of cardiology at Sri Jayadeva Institute of Cardiovascular Sciences and Research for decades, and continues to be associated with that particular organization even today. And she's going to share her experience about managing our patients with congenital heart disease who would have had grown into adults with or without repair and with or without symptoms. Managing the real world patients with heart diseases as adulthood carries their own challenges, including challenges of pregnancy, challenges of other associated morbid conditions, or even otherwise the lifestyles. Let's listen to Professor Prabhavathi for her guidance. And also, we are extremely grateful to her for agreeing to be part of this faculty of 5th Cardiovascular update on behalf of Karnataka Cardiology Academy. Dr. Prabhavathi, please. Go ahead.
Thank you, sir. Respected chairpersons and dear friends. At the outset, I would like to thank Dr. Nagaraj Desai and his team for giving me this opportunity. The topic is managing a grown-up adult with congenital heart disease, pearls of wisdom. Incidence of congenital heart disease at birth is 8 per 1,000 live births. The most common being ventricular septal defect, which occurs in 40%. This excludes the bicuspid aortic valve, which is seen in 1 to 2% of the population. The survival to adulthood depends on the natural history. Conditions with favorable natural history survive to adult life without any interventions, whereas conditions with unfavorable natural history can live with corrective or palliative procedures, barring exceptional survivors. For example, children born with transposition of great arteries or obstructed TAPVC or hypoplastic left heart syndrome present very early in infancy and do not survive without treatment. Whereas small shunts bicuspid aortic valve may present in middle age and may go on to older age also. The most frequently seen congenital heart disease in adults are simple left to right shunts. The most common being atrial septal defect, which makes up to 40% of the congenital heart disease seen in adults. Bicuspid aortic valve with a prevalence of 1 to 2% can present throughout life with aortic stenosis, aortic regurgitation, infective endocarditis, or aortopathy. Other obstructive lesions like coarctation of aorta and pulmonary stenosis also present in adult life. More complex lesions like ventricular septal defect with PS, otherwise called Pinktoff, mild Epstein's anomaly, corrected transposition of great arteries also make their appearance during adult life. Among the cyanotic congenital heart disease in adults, tetralogy of Fallot is the most common, which forms up to 80% of the cyanotic congenital heart disease. The next common is Eisenmenger syndrome, which presents during 2nd to 4th decade. Rarely, Epstein's anomaly, TAPVC, may present first time in adult life. Nowadays, we see more often operated congenital heart diseases. Most frequently, completely repaired congenital heart diseases like atrial septal defect, VSD, coarctation of aorta, or tetralogy of Fallot. Some patients with even palliative repairs like shunts, BTT shunt, or Glenn shunt may survive into adult life. European Society of Cardiology has classified the congenital heart disease complexity to mild, moderate, and severe. Most of these patients may present with heart failure, which is the leading cause of death. Other complications are arrhythmias, thromboembolic complications, pulmonary arterial hypertension, and infective endocarditis. Congenital heart disease is a lifelong chronic disease with reduced life expectancy. They will need repeat hospitalization, need for re-interventions, re-operations. They need lifelong medical therapy, reduced quality of life, risk of endocarditis, pregnancy-related complications, arrhythmias, and sudden cardiac death. Moving on to management, we'll focus mostly on the most common lesions, atrial septal defects being the most common congenital heart disease in adults. Second ASD constitutes about 80% and sinus venosus defect up to 5%. These present usually after the fourth decade of life. Primum ASD may present earlier because of associated mitral regurgitation due to cleft mitral valve. When to close ASDs, the ideal age is between 2 to 5 years. Surgical repair has a very low mortality, less than 1%. Outcome is best if ASD is closed before the age of 25 years. Closure after 40 years does not prevent atrial arrhythmias, but closure at any age improves exercise capacity and right heart failure, provided device closure can be done. Device closure has a success rate and mortality similar to surgery. Serious complications are very rare, less than 1%. These patients need antiplatelet therapy with aspirin 75 milligrams once daily for at least 6 months. Morbidity is lower and the hospital stay is shorter with device closure. Which ASD need to be closed in adults? Small ASDs where the shunt is less than 1.5:1 need not be closed. Patients with evidence of RV volume overload and echo suggestive of left to right shunt more than 1.5:1 need to be closed provided the PA pressure is normal. If the echo shows higher pulmonary artery pressure, then invasive assessment of pulmonary vascular resistance is needed, provided if it is less than 3 Wood units, they benefit more. They are the ideal candidates for closure. Device closure is the method of choice for ostium secundum ASD. In elderly patients, if they're not suitable for device closure, the surgical risk should be weighed against potential benefit of ASD closure. If the pulmonary vascular resistance is between 3 to 5 Wood units, ASD closure should be considered provided the left-right shunt is more than 1.5:1. This is class 2A indication because it is associated with decrease in pulmonary artery pressure and improved symptoms. If the PVR is more than 5 Wood units, European guidelines says give PAH therapy. If PVR drops below 5 Wood units, then a fenestrated ASD closure may be considered if the left-right shunt is more than 1.5:1. Suppose the PVR remains more than 5 Wood units, it's a contraindication for closure. Resting or exercise-induced desaturation is a contraindication for closure. Vasoreactivity testing is not recommended in patients with ASD pulmonary hypertension. Recommendations for VSD and PDA closure is more or less similar. Moving on to bicuspid aortic valve, which is the most common congenital heart disease and the most common cause of aortic stenosis with a lifetime incidence of AS up to 80%. The small risk of aortic regurgitation up to 15% is seen. Majority of them, up to 80%, may develop ascending aortic dilatation due to aortopathy, with an increased risk of aortic dissection. They have a small risk of infective endocarditis, 0.3% per year throughout life. Coarctation of aorta is associated with bicuspid aortic valve in up to 10%, so we should look for coarctation in patients with bicuspid aortic valve. Familial occurrence of bicuspid aortic valve is seen in 5 to 10% of the first degree relatives. So the first degree relatives should undergo echo screening. If they develop aortopathy, there is no evidence for medical treatment. However, beta blockers and ARBs should be considered as first-line treatment if they develop hypertension. If aortic dimension is more than 50 millimeter, it's a contraindication for pregnancy in patients with bicuspid aortic valve. Symptomatic severe aortic stenosis need intervention. In selected adolescents and young adults with non-calcified valves and no significant aortic regurgitation, balloon valvuloplasty may be considered. Pregnancy is contraindicated in severe symptomatic aortic stenosis. Balloon valvuloplasty or surgery should be done before conception. If aortopathy is there without aortic valve involvement, surgery should be considered if aorta is more than 55 millimeter. Coarctation of aorta is a generalized arteriopathy with a high incidence of bicuspid aortic valve up to 85% and increased incidence of ascending aortic aneurysms. They have a 10% risk of intracerebral aneurysm with increased risk of intracerebral bleed. When do we need to repair a coarctation or recoarctation? Hypertensive patients with a peak-to-peak gradient more than 20 millimeter mercury across the coarctation should undergo repair or repair by surgery, but stenting has become the first choice now. Covered stents are preferred because of the lower complication rates. Balloon angioplasty alone should be reserved for redilatation of previously stented coarctation of aorta. Coarctation with complex anatomy like interrupted arch or long segment coarctation should undergo surgery. Moving on to tetralogy of Fallot, which is unrepaired or unoperated. This is the most common cyanotic congenital heart disease in adults because 25% survive at 10 years and 11% at 20 years. Corrective surgery can be done with a mortality less than 5%, but morbidity, bleeding risk is higher. In high-risk patients or unsuitable anatomy, a palliative balloon dilatation of the pulmonary valve or REOT stenting can be done. Nowadays, we see more of operated tetralogy of Fallot. Their 40 years survival may be up to 90%, but they still need annual checkup because of expected complications. After a transannular patch repair, significant pulmonary regurgitation occurs in all these children. This PR is progressive, usually well tolerated for many years. Eventually, they develop symptomatic RV dilatation, dysfunction, and tricuspid regurgitation. These patients will need pulmonary valve replacement, either surgical or intervention. Other complication in operated TOF can be residual RVOT obstruction, which may need redo surgery, or residual VSD, which can be closed with the device. Progressive aortic dilatation and aortic regurgitation can be seen in small % of patients. They may present with heart failure due to ventricular dysfunction. Atrial ventricular arrhythmias can occur and rarely sudden cardiac death, especially if the QRS duration is more than 180 milliseconds. Cyanotic patients in general present with multi-system disorder. They are at risk for both bleeding and thrombotic complications. Hence, unnecessary use of aspirin, NSAID, and anticoagulation should be avoided. Earlier, routine phlebotomies were done in these patients, but it must be avoided because it leads to iron deficiency anemia and increased risk of stroke. So when to do phlebotomy? Patients presenting with severe hyperviscosity symptoms with a hematocrit value more than 65 to 70%. Remember, we need to rule out iron deficiency anemia and dehydration because they can have similar symptoms. Remove 300 to 500 ml of blood with saline replacement. And again, iron supplementation is a must to avoid iron deficiency. We need to follow some risk reduction strategies in patients with cyanotic congenital heart disease. Pregnancy should be avoided if the oxygen saturation is less than 90%, as it increases risk both to mother and the baby. Use of air filter in IV line to prevent air embolism. Avoid dehydration, strenuous exercise, and exposure to heat, which can precipitate symptoms. Prevent infections with administration of influenza and pneumococcal vaccines. Infective endocarditis prophylaxis is recommended in all patients with cyanotic heart disease. Finally, pulmonary artery hypertension in shunt lesions. It's a progressive disease with poor prognosis. Even after defect closure, PH can progress. Hence, regular assessment is recommended in patients who have undergone shunt closure. Medical management is the only option because surgery is not possible in most of the patients. Initial combination therapy or a sequential combination therapy with sildenafil or tadalafil plus bosentan or ambrisentan is recommended. High-risk patients should be treated with initial combination therapy, including even parenteral prostanoids. Eisenmenger syndrome patients live longer, so they need to be educated properly. Patient education is very important. They should avoid volume depletion, extreme heat, strenuous exercise, high altitude, and long distance air travel. Non-cardiac surgery is associated with high risk, so it should be done cautiously, avoiding systemic vasodilatation. Eisenmenger syndrome is an absolute contraindication for pregnancy. What are the other contraindications for pregnancy in congenital heart disease? The lesions with a very high risk, up to 40 to 100% risk, like pulmonary hypertension of any cause, including Eisenmenger syndrome, severe LV dysfunction with EF less than 30%, systemic right ventricle like in corrected transposition with moderate to severe dysfunction, severe symptomatic aortic stenosis, severe coarctation, aortopathy with aortic dimension more than 50 millimeter in bicuspid aortic valve and more than 45 millimeter in Marfan's. And finally, Fontan with any complications. These are absolute contraindications. Estrogen-containing contraceptives are harmful and should be avoided in congenital heart disease with high risk of thromboembolism, like cyanotic heart disease, Fontan physiology, pulmonary artery hypertension, and prosthetic mechanical valves. To summarize, adult congenital heart disease is a growing challenge. Incidence depends on the natural history. Operated congenital heart diseases are increasing now. The management is complex and multidisciplinary approach is necessary to treat these grown-up congenital heart disease patients. Thank you.